on page 215, we want to focus on page 215 on blood flow, especially through the systemic circuit. And there are many ways of depicting how blood flows through the systemic circuit. In this diagram, it reminds us that the left pump pumps the blood through, out into the aorta, through the systemic vessels, and the blood comes back to the right pump. And of course, the job of the right pump is to pump blood through the lungs. Another diagram, another way of representing this is here it represents the heart and the lungs as the pump oxygenator unit. And if that sounds a little weird, in fact, there is a machine that basically does the job of the heart and the lungs. It's called a heart-lung machine that a patient is placed on during open heart surgery. And basically what the pump oxygenator then does is it oxygenates the blood and pumps the blood through the systemic circuit. First through the arteries, then the capillaries, and then it comes back to the veins of the body. But then there's an even more famous way of depicting the flow of blood through the systemic circuit, and that's my very famous, and maybe not so famous, water faucet model. And this is the model that I've come up with for trying to depict and describe how blood flows through the systemic circuit. Basically, we know that it's a recycling system. The blood that is ejected out by the heart into the aorta goes through the systemic circuit and it returns right back eventually to that same water faucet, as it were. So however much blood is coming out, the amount of blood that returns back, and we know that the term for the return of blood back to the heart is called venous return. How much blood is coming back, or the venous return, will ultimately affect how much can then be ejected out, which is called cardiac output, because it's a recycling system. Now, there is a formula for relating flow, pressure, and resistance in describing the flow of fluids in any system of pipes. The amount of flow depends upon the pressure. It is directly proportional to the pressure and inversely proportional to the resistance, or whatever hinders the flow of fluid through those pipes. Now, to take those same terms, water flow, water pressure, and resistance to water flow, to turn them into more cardiovascular terms, the term that we use for the flow of blood, the amount of blood flowing through our pipes or our vessels per minute, is cardiac output. And the term for pressure is blood pressure. And the term for resistance, we'll just use resistance for the moment, but we'll get to the technical term in just a moment. Now, in fact, we can rearrange these three terms. We know that if we know any two of these terms, we can solve for the third. So rearranging these terms, as you can see at the bottom, at the very bottom, we can rearrange them so that pressure is equal to flow times resistance, or using our cardiovascular terminology, the arterial blood pressure, and to be more precise, the average or mean means average, the mean or average arterial blood pressure is equal to the cardiac output, which we know refers to blood flow, multiplied times the TPR. TPR stands for total peripheral resistance. And what TPR is whatever factors that hinder the flow of blood through the pipes or vessels of the body. So we're going to be referring to this formula, this relationship, as we go on. So this is a second formula. The first formula that you should know for the test next week is cardiac output equals heart rate times stroke volume. This is a second formula. Average arterial blood pressure is equal to cardiac output times total peripheral resistance. This is page 249, and this is my water faucet model shown with even greater detail. And what we see here is the blood pressures in our vessels. And you'll notice that in the big arteries, which are represented by this segment of the hose, the average blood pressure, and BP with a line over it means average blood pressure, or mean blood pressure. Mean, M-E-A-N, means average. The mean or average blood pressure in our big arteries is about 90 millimeters of mercury. The numbers that you're more familiar with, and I'm going to connect it all together yet today, is 120 over 75. But if your blood pressure is about 120 over 75, the average is about 90. Going up and going down, so the average is 90. I'll explain how we got that later. Now, interestingly, by the time the blood gets to our little arteries, our arterioles, the blood pressure has dropped to 35. By the time the blood gets to our capillaries, the blood pressure in our capillaries is about 26. 26. That should ring a bell. Didn't we learn about how there's the blood pressure in the capillaries that forces water out of the capillaries? And that capillary blood pressure is normally 26 millimeters of mercury. And then there's an osmotic pressure due to proteins drawing water in of 25. Remember those numbers? That's the 26. By the time the blood reaches the veins, it's down to 15. By the time it reaches the vena cavae and right atrium, it's down to 5. This blood pressure in our big veins, our superior and inferior vena cavae, is known as the CVP, or central venous pressure. Is everybody writing that down? Well, we already learned it. You'd say, when did we learn it? Page 202. This was page 202, which we need to know for the test coming up, because on page 202, didn't we say that when you put a catheter to measure blood pressures, the blood pressure you measure right here in the superior vena cava and right atrium, here it was, that's called the central venous pressure. And it's down around, look at that, around 5. So this is all coming together now. That's why that's so low. So back where we were on page 249. So notice what happens to the blood pressure as you move further and further away from the faucet. It goes down. Let's just show you a couple last things before we take a break. Let's take a look at a picture on page 227. Page 220, look at this quality of this picture. Look at this art quality. Now, let me ask you this question, because I'm using this garden hose because I think we can relate to it. So imagine we have a faucet and we have a garden hose that's 10 feet long, and we have a garden hose that's 75 or 100 feet long. You turn on the faucet. Can everybody relate to the fact that your water pressure is going to be better here than at the end of this? Can you relate to that? If you had this long hose and it had holes in it, wouldn't the water squirt out highest close to the faucet? And the whole water would just be dribbling out a little bit, way 100 feet away from the faucet. Can you relate to that? Now, if you don't have to, you could say, I can't relate. Then your job between now and next time is to get a garden hose and try the different length hoses and try and see if you can see a difference in water pressure between a short hose and a long one, if you don't believe me. Right? So that's okay. You don't have to believe me. I want you to try it. You can demonstrate it. Or just take a brand new garden hose and put holes in it and turn on the water, and you'll see it squirts out highest near the faucet, and it squirts out progressively less and less and less the further downstream you are. So what we're seeing is this is a basic concept of water flow or fluid flow, hydraulics. The farther downstream you are from the source of the pressure, which is the faucet, the lower your pressure. There is what's called a drop in pressure, a pressure drop. based on the distance. So with that in mind, and we'll just complete this thought before the break. So back on page 249, that's why this blood pressure is dropping. Because as you get further and further away from the source. Now, in the afternoon class, somebody said, yeah, but the vein, that's closer to the faucet. Well, wait, yeah, but if we disconnect it from the faucet, can everybody see the vein is farthest away from the faucet? Right, they said, see, it's back out, same distance. No, it's, okay, it's the hose and it's just coming back. So, now, one last point. What if, on the final exam, on the final, not the third exam, what if I asked you the following question, which I probably will. True or false? True or false? The blood pressure in your capillaries is higher than that in your veins. True. Your blood pressure in your capillaries is higher than in your veins. Because your veins are even further downstream from your heart, your faucet. Now, we're going to skip page 216 and 217, and I'm not likely to come back to it. It's not that it's unimportant, but we're short on time. So we are on page 218 at the bottom. And on the bottom of 218, I want to explain that term I've just given you, total peripheral resistance, or TPR. So what is peripheral resistance? The total hindrance. And you might say, what's hindrance mean? Hindrance means whatever preventing the flow of blood. Whatever is hindering or preventing the flow of blood is called the total peripheral resistance, or vascular resistance. Now, there are a number of factors that can hinder or prevent or reduce the forward flow of blood through our vessels. I'm only going to give you two factors, just two. The most important of the factors that can increase resistance or hindrance to flow is how constricted or dilated our little arteries are, called arterioles. It is the small muscular arteries, called arterioles, that are the most important vessels in our body that constrict or dilate. Our large arteries, you might say, well, what about our big arteries, like our aorta? The large arteries of the body do not constrict or dilate. They don't even have, and you actually would have learned this in your anatomy class, we commonly call the large arteries of our body the elastic arteries, because in the wall of the big arteries there's elastic connective tissue, but there's really no smooth muscle. So therefore they can't constrict or dilate. So the important arteries that constrict or dilate are the small arteries called arterioles. They have the visceral smooth muscle that is innervated by autonomic motor neurons that can be caused to constrict or dilate. Now, to help you understand this better, let's look on 219. And we're going to try to explain this both intuitively and analytically. And I want to first explain it intuitively. Right? We'll appeal to just how you'll say, yeah, that makes sense. And then I'll show you analytically. Let's use, we've got a water faucet and a garden hose. Let's imagine we've got a faucet and a hose. You could do this at home. All right? You turn on the water. The water's going through the hose. If you squeeze the hose anywhere along that hose, what are you doing to the resistance? You're increasing resistance. You're making it harder for the water to flow past where you're squeezing it. Does that make sense? And what is that increased resistance, what is that doing to the pressure in the segment of the hose between the faucet and where you're squeezing it? It's raising the pressure. Can you visualize that? So if you don't believe me, just try it. So here's what we're saying. You've got the faucet on, water's coming out, really blood, and if most of the little arteries in your body were to constrict, can you see that that's increasing the resistance? It's making it harder, it's reducing the flow of blood through these constricted vessels, and it's raising the pressure right here in the big arteries. You got that? That's it. It's not a complicated concept. Now, let's show you this analytically. We had learned that the average blood pressure in our arteries depends upon cardiac output and total peripheral resistance. That's that formula I just showed you. So let's assume the amount of cardiac output, how much water is flowing, let's assume is constant for the moment, 5 liters per minute. But let's imagine that all of these arterioles throughout your body were mostly constricting. That constriction increases the resistance. And according to this formula, any increase in resistance will have what effect on your blood pressure in this segment? It will increase the arterial blood pressure. So the formula is if you increase peripheral resistance, then the blood pressure goes up. You got that? So now we know that whenever most of the blood vessels in our body constrict, the peripheral resistance increases and that raises our blood pressure. Isn't that what happens with our sympathetic motor neurons? Back on page 105, when we contrasted sympathetic versus parasympathetic, didn't we learn during stress? Don't most blood vessels of our body constrict? Okay, now a lot of people are going, what? Okay, you got to know that. That would be basic information that you would need to know for the final. Honest, you got to know that. We know there's generalized vasoconstriction. The vessels through our GI tract constrict. The vessels to our kidneys constrict. The vessels through most parts of our body constrict. The exceptions are the heart and skeletal muscle. They dilate. But all the other vessels everywhere else constrict. Generalized vasoconstriction. Didn't we also learn that during a stress state, what did we learn happens to your blood pressure? Goes up. This is the major factor. The other major factor, and we can just jump ahead, during stress, what happens to your cardiac output? That goes up. So look, if cardiac output goes up and vasoconstriction increases peripheral resistance, that goes up, then for sure your blood pressure goes up. So that's why your blood pressure rises. Both of these are actually going up during stress. But right now we're just focusing on peripheral resistance. So sympathetics cause generalized overall increase in arteriolar vasoconstriction, increasing total peripheral resistance, which leads to both intuitively and analytically a rise in your average blood pressure in your big arteries right here. Again, just take a garden hose if you don't believe me. Now, let's consider the opposite. If constricting most of the vessels in your body increased resistance and raised the arterial blood pressure, then what's got to happen if most of the blood vessels in your body dilated? It's got to be the reverse. Your peripheral resistance would drop. Just imagine, if all the vessels start dilating, they're all dilating, opening up. If you let go of the hose, the resistance drops and that increases the flow. But what does that do to the pressure? It lowers the pressure in that first segment of the hose when you let go of you're squeezing your hand. So that's why I'm using my water faucet garden hose model, because you can practice this at home. Just all you need is a water faucet and a garden hose. Let me give you an example of something that would cause essentially all the blood vessels in your body to dilate. An allergic reaction. We're going to have more to say about this, but in an allergic reaction or hypersensitivity reaction, your cells release chemical mediators of inflammation, including histamine. You know what histamine does to all the blood vessels in your body? It dilates them. If all the blood vessels are dilating, that drops your peripheral resistance, and what's going to happen to your blood pressure? It drops. So you know what we call an allergic reaction? Anaphylactic shock. Shock means a drop in blood pressure. And that's what's going on, is massive vasodilation. Incidentally, does anybody know what medicine is given to anybody in anaphylactic shock? Adrenaline, epinephrine. A lot of the people who are prone to allergic reactions carry something called an EpiPen with them. And they give themselves an injection of epinephrine. What does epinephrine going to do to most blood vessels of the body? Constrict. It counteracts the effect of histamine. And that way, by constricting the vessels, it raises the blood pressure back up. You got it? That's how this is working. So we kind of analyzing it. Now, the second factor that, and the last factor that we're going to learn that affects the total peripheral resistance is the degree of vascular stenosis. What does stenosis mean? Narrowing. We use the word stenosis or occlusion. This is due to atherosclerotic plaque. Atherosclerotic plaque, this buildup of crud, of fat, on the inside walls of our vessels is making the lumen or passageway narrowed, constricted, stenotic, occluded. All those words mean the same thing. That's also going to increase total peripheral resistance and raise blood pressure. Let's understand it intuitively. Look, it's really simple. Can you see that if this crud builds up on the inside wall of the vessel, making the lumen narrower, isn't that effectively the same effect as if the vessel had constricted? So if we've agreed that constricting the vessel raises resistance, this is effectively the same as constricting because the lumen has gotten narrower, right? And that's why atherosclerosis leads to high blood pressure. It raises the peripheral resistance, and that raises the pressure in that segment of the vessel that's clogged up. You got it? That's basically why this clogging up effectively is the same effect as if the vessels had constricted. And that anytime you increase peripheral resistance, you raise blood pressure in the vessel. All right, so you should know that. We're going to jump to 221. And on page 221, we're going to just review a little bit more about blood pressure. Because blood pressure is kind of really important. For most of you, in terms of whatever clinical field you're going to go into, you're going to be taking blood pressures all the time. And you need to understand what's going on. Now, let me first remind you of this. Our blood pressure in our arteries goes up and down, up and down. Every time our heart contracts and ejects blood, that's called systole, the blood is ejected out into the aorta and therefore into the rest of our vessels, and the blood pressure in our arteries goes up. That's called your systolic high. Every time the ventricle relaxes so it can refill, when it relaxes, that's called diastole. And the blood, since the heart is no longer ejecting the blood out of the artery, the blood pressure drops. Now, here's the question, what determines how much the blood pressure drops during diastole? You'd say, what do you mean? Well, obviously, what we're saying is this. How high your systolic blood pressure goes, either real high or real low, is largely determined upon the force of contraction of your heart. If your ventricle ejects a lot of blood, that raises the systolic blood pressure. If it ejects less, the systolic won't be as high. But what affects the diastolic of how high or low the diastolic is? It can't be the heart, because the heart's not doing anything during diastole. So what is the major factor that affects how high or low the diastolic blood pressure is? You see in our picture, they have a picture of the vessels. That's to represent what the major factor that's affecting how high or low the diastolic blood pressure is the total peripheral resistance. Now, we just summarized two factors that affect total peripheral resistance. What were the two factors we gave you? The most important is the overall degree of arteriolar vasoconstriction. The second factor was the degree of stenosis, clogging up of our arteries by plaque, atherosclerotic plaque. So, if you have overall arteriolar vasoconstriction or atherosclerosis, that raises peripheral resistance, and that especially raises the diastolic arterial blood pressure. That's also called the afterload. It impairs, it makes it harder for the ventricle to eject blood. Now, it's for this reason that many of you know that when they look at somebody's blood pressure and it's systolic over diastolic, the number they especially like to look at is the diastolic. Is anybody familiar with that? And the reason why is because the higher that diastolic blood pressure, it's an indication of, to some extent, of the severity of the atherosclerosis in those vessels. Now, at the top, what is our normal blood pressure in our systemic circuit? Most of us, you've had your own blood pressure taken with a pressure cuff. Typically, we get blood pressures in our systemic arteries of 120/75. But there is an acceptable range, and I want you to know this for the final. The acceptable range is 90/60 to 140/90. If your blood pressure falls within that range, you may be on the low side, you may be on the high side, but they probably won't do anything. But if your blood pressure is lower than 90/60, we say you have hypotension or you're in shock. You got to raise it. It's too low. If your blood pressure exceeds, if it's greater than 140/90, you have high blood pressure, hypertension, and they're going to put you on antihypertensive medication. We had actually learned that number, 140/90, on page 272. Okay? So any blood pressure greater than 140/90 is defined as high blood pressure. So we have to have definitions. It's just like your blood sugar level. How low or how high does it have to be where it's considered no longer within the normal range? Same thing with your thyroxine level. We measure the thyroxine level. It's got to be outside the normal range before we consider you hypo or hyperthyroid. All right, so we've talked, one more thing. What's the blood pressure in our pulmonary arteries? And I'm not going to ask you to know the range, but I am going to ask you to know what a normal pulmonary arterial blood pressure is. It's 25/10. Have we ever mentioned that before? The answer is yes, and we specifically mentioned it on page 202. On page 202, this was page 202. Does anybody remember on 202 where we talked about when we put a catheter in, we can measure the blood pressure, the central venous pressure, the pressure in your right ventricle, and the pressure in your PA, your pulmonary artery. And what did we show was the blood pressure in the pulmonary artery? 25/10. Right? So that's a different kind of blood pressure than in your systemic circuit. All right, so much for that. Let's look on the next page, 222. And on page 222, we're going to go to the middle of the page. And again, anything I skip, assuming I don't go back to it, you don't have to know. And next week, I'll make sure everybody's clear. I don't try to deceive anybody. I'm mean and cruel, but I don't try to be tricky. So we'll make sure you only study what I'm going to ask you to hold you responsible for. Let's talk about PP. 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 All right? PP is pulse pressure. Now, pulse pressure is the difference between the systolic high and the diastolic low. So in somebody who's got a typically normal blood pressure of 120/75, their PP or pulse pressure is 120 minus 75 or 45. This 45 really represents the driving force created by your ventricle. You might say, I don't get that. So here's what I mean. If this room is the left ventricle and this is the aortic valve, right? So if I begin to push the aortic valve open at about 75, 80, let's say 75, then the pressure rises. The left ventricle raises the pressure by 45 millimeters of mercury up to 120. So effectively, the ventricle raised the pressure in that aorta from the 75 that it started out, or 80, and it raised it to 120. So how much did your left ventricle actually increase the pressure in your aorta by? It raised it by 45 millimeters of mercury. So that was the driving force generated. That's how much your ventricle raised the pressure in your artery. From that low of 75, it raised it up to 120. It raised it by 45. So basically, when they measure the pulse pressure, when they subtract the systolic from the diastolic, that's really an indication of the power of the ventricle to raise the pressure. Now, I'm not going to get into a lot of details on this. I will say this much, that during very strenuous exercise, you tend to see the systolic go up, and either the diastolic remains the same or it may even go down. But the main point I'd like to make is when you measure somebody's blood pressures during exercise, you will see the way they express it is they'll call it a widening of the pulse pressure. It becomes bigger. Can everybody see here if the systolic increased to 160? You'd say, why? Because your heart contracts more powerfully during exercise. And therefore, it raises the systolic blood pressure. If you don't believe me, all you have to do, when you're exercising, your blood pressure goes up. And that's especially the systolic. Even if the diastolic, and I show it going down, I'm not going to explain why, but even if it stayed the same, systolic certainly increases. Can everybody see, therefore, the pulse pressure becomes bigger? That increasing or widening of the pulse pressure is an indication of increased effort by your heart. So that's how they evaluate pulse pressure. That was simply pointing out something I mentioned last time. I said if you had high blood pressure, and basically what we're especially looking at is the diastolic. If the lowest that the blood pressure ever gets in the aorta is not 75 but 95, then the ventricle, in order to eject the same 70 milliliters of blood that it normally does, has to raise the blood pressure in the aorta by the same normal 45 millimeters of mercury. So it'll have to raise the pressure from 95 to 140 in order to eject the same amount of blood. It's got to increase that pressure. The starting point normally is 75. Then it raises at 45 up to 120 to eject 70 milliliters of blood. If the starting point where it begins to eject blood doesn't begin till 95, it's got to raise it by 45 up to 140 millimeters of mercury to eject the same volume of blood. So the higher the diastolic, basically it's forcing the heart to work harder to eject the same amount of blood. Now, another concept, it's interesting about all this. When you're thinking of blood pressure, up till now, you were thinking it was all simple and straightforward. Right? You were thinking, yeah, you just take the blood pressure and there it is. That's because there's all this understanding of what it means. If there wasn't, as I've said before, why would anybody have to study 4 years after medical school to become a cardiologist? What more could there be? You take a blood pressure and that's what it is. All right, now, I want to talk about estimating that mean. What is mean? Average arterial blood pressure. Now, we have said that your blood pressure is a typical normal blood pressure is 120 over 75. Is that okay? Now, if I was going to ask you, how do you normally calculate an average? The way you normally determine an average is you'll take the two numbers and add them together, divide by 2. Isn't that right? So our thought would be, if the high is 120 and the low is 75, I'll add 120 and 75 together and divide by 2. That's not what we do. Why not? Why not? Because I'll remind you that at the resting heart rate, the time during which your blood pressure is rising, increasing, lasts 0.3 of a second. That's called your systole. But the time during which your blood pressure is dropping lasts almost twice as long, 0.5 of a second. That's called diastole. So in other words, we learned that systole and diastole don't last the same amount of time. The pressure spends almost twice as long going down as it does going up. It goes up and then it goes down. It goes up and then it goes down. So A closer approximation of the average is to use this formula here. It's very simple. All the math we do is very simple. We take 1 times the systolic plus 2 times the diastolic and divide by 3. You'd say, why? Notice what we're doing is we're weighting the diastolic, we're giving it twice the weight or value as the systolic, because the pressure spends almost twice as long going down as it does going up. So let's calculate this right now. If somebody's blood pressure was 120 over 75, right now, why don't you tell me, calculate what their average is? All right? We'll give other people just a second to figure it out. All right, so you're going to take 1 times the systolic. What's the systolic? 120. Plus 2 times the diastolic. What's diastolic? 75. So multiply that times 2. 2 times 75. Add them together and divide by 3. Now, do you think I'd give you something like this on a test? Yes. All right, so that's going to be 1 times 120 is 120, plus 2 times 75, that's 150. So 120 plus 150 is 270. Divided by 3 is 90. So the average blood pressure is about 90. Now, our next question is, well, who cares? And we're going to be learning very shortly that the cardiovascular reflex center in the medulla oblongata's job is to maintain the average blood pressure in your arteries. It's not trying to regulate your systolic high or your diastolic low. It's trying to maintain the average at about 90. So that's why we want to be able to estimate the average. All right, on page, we're going to jump now. We're going to skip a few pages, some of which we will come back to, most of them not. But let's look on page 226. And on 226, so this is basically describing something that we have already covered today. What did we write in the middle of page 226, underline? As the blood flows downstream, the pressure goes down. The farther you are away from the faucet, which is the heart, the lower your blood pressure. That's what these graphs are showing. This is showing the drop in blood pressure in your systemic circuit, and this is showing the drop in blood pressure in your pulmonary circuit. And we're focusing more on the systemic than the pulmonary. So notice, here it's showing that in your aorta and large arteries, the blood pressure goes up to 120, down to 75 or 80, right? It's got an average, as we've just calculated, of about 90. And then you'll notice a couple of things. First, as the blood flows into the arterioles and capillaries, you'll notice we no longer have a pulse pressure. We no longer have a systolic high or a diastolic low. We have one continuous pressure. So we only have this systolic over diastolic in the arteries. We don't see it systolic or diastolic in capillaries or veins. Furthermore, the pressure is dropping. In the capillaries, it's about, we've learned about 30, the arterioles is about 35, and the capillaries about 26, and the veins 15. And by the time we get down to the vena cava and right atrium, it's down to almost 0, it's about 5. So it progressively drops. Same thing is happening, it's dropping also in the pulmonary circuit. It starts out lower, 25 over 10, and then it drops there. But this is just summarizing how the blood pressure drops. And at the bottom of the page, I just remind you, there's no pulse pressure, no PP, no difference between systolic over diastolic downstream from the arteries or arterioles. Incidentally, one more important point. You know, we just talked about PP. What's PP? Pulse pressure, the difference between systolic high and diastolic low. Don't confuse pulse pressure with pulse. What is pulse? Pulse is when you feel or palpate an artery. Are you trying to determine somebody's blood pressure? Their heart rate. And you're not feeling blood pressure. You're feeling a vibration created by the ejection of blood. So when you take somebody's pulse, you're determining their heart rate. Pulse pressure is the difference between the systolic high and the diastolic low. Right, so just make sure, I understand it's confusing. I didn't invent the words. But we do, you know, if they say check the person's pulse, don't subtract systolic over diastolic. And if they say what's their pulse pressure, don't say, well, they're at 75 beats a minute. That's not the pulse pressure. Okay, we're going to jump ahead to page 249. We've already done page 249. I'm just going to remind you. So this page 249 was just a picture of my amazing water faucet garden hose model where it shows how the blood pressure drops. Notice on 249, so normally how much water is coming out the faucet each minute? 5 liters per minute. That's the flow. It can increase or decrease. And what's the blood pressure in our big arteries? About 120 over 75. But we can calculate the average. If you take 1 times the systolic plus 2 times the diastolic and divide it by 3, the average mean arterial blood pressure is 90. That's what we calculated. By the time we get to the arterioles, it's about 35. By the time we get to the capillaries, it's 26. By the time we get to the veins, it's 15. By the time we get to the central venous pressure, vena cava, it's down to 5. We know that the blood pressure in the capillaries causes water to squirt out. So in my advanced picture, I even showed the lymphatic system. It's kind of cute, isn't it? There's the lymphatic system. What does the lymphatic system do? Its job is to take that excess water that's squirted out of the capillaries and bring it back to the bloodstream. Anybody remember where the lymphatic vessels connect to your bloodstream?
Subclavian.
Good, subclavian veins. So it goes back into the veins. All right, so there's my model of even where that connects. Now, on the next page, 250, what are the factors affecting venous return? Incidentally, obviously, on this picture, I show that this flow of blood back to the water faucet is called VR, venous return. So, you know, the problem is the blood pressure in our veins is really low. So the veins need help to get the blood back to our heart because the pressure is so low. And what especially tends to reduce that flow of blood back to the heart is gravity. You know, because when you're standing up, isn't gravity pulling everything down to your feet? So that means that the blood really doesn't want to go back up to your heart, from your legs, all the way up your legs back to your heart, because gravity's pulling everything down. So the veins kind of need help. So what helps them? On page 250, factors affecting venous return. First thing that helps them, there are valves that prevent backflow in our veins. We don't need valves in our arteries because there's a really high pressure in the arteries. But we've said earlier today, in our veins, there are valves that if they're working, that prevents the blood from going backwards. Another thing that helps is the sucking action of inhaling. Every time when we inhale, the pressure in our chest goes down. Inhaling lowers intrathoracic pressure. It creates basically a kind of suction. Look, we're going to learn more about this when we get to respiratory, but when you enlarge your chest, the pressure inside goes down. And I'll tell you why, and I'll explain this better at another time. Those of you who've had chemistry, it's Boyle's law. You'd say, what the hell was Boyle's law? Pressure is inversely proportional to volume. When volume increases, pressure decreases. When you enlarge the chest size, the pressure inside the chest goes down. That creates a suction, and that's what sucks or draws air into your lungs. And it also acts to suck or draw blood towards your chest to your heart. So this inhaling lowers, see how everything is interconnected? It creates it lowers the intrathoracic pressure, sucking or drawing blood back to the heart. And it also sucks air into your chest, into your lungs. All right, incidentally, if inhaling sucks, exhaling blows. We see an increased pressure, and we touched upon this with the Valsalva maneuver. That's why you're seeing changes in your heart rate related to breathing, because you were affecting blood flow. Another thing that affects that helps affect venous return is contracting our muscles. Haven't we learned that when we contract a muscle, it squeezes all the little blood vessels within it? And squeezing the vessels within a muscle, the blood flows forward. It can't go backwards because of valves. And finally, veno constriction. The veins are controlled by autonomic motor neurons, and when they constrict, it squeezes the blood towards the heart. Again, we talked about this earlier. You might say, well, if the veins can squeeze, won't the blood go backwards? No, why not? Because the valves prevent it from going backwards. So it has to be, it's going to be squeezed, it's going to be squeezed forward towards the heart. Veins carry blood to the heart. All right, so those you should be familiar with. Incidentally, under clinical considerations, what are varicose veins? That's when the valves don't work. So instead of the blood flowing through these veins of your legs back to your heart, the valves are not working right. The blood doesn't go forward, it flows backwards, and the veins become distended and engorged with blood. That's called varicose veins. It's a valve problem.